Welcome to our video on dementia. Let's begin. In this lecture, we are covering the general characteristics, differential diagnosis, clinical approach, and treatment of dementia. Let's begin with general characteristics. We can simply define dementia as a common cause of declining intellectual and cognitive function, and a common cause of mortality in the elderly. Dementia is a general term applied to patients with impaired memory, orientation, visuospatial skills, language, and executive functions like planning and daily living activities. It is characterized by a preservation of consciousness, meaning the patient is able to respond on command and his or her memory is intact. The major risk factor for dementia is increasing age. Some degree of forgetfulness is normal in the elderly. So in order to differentiate between benign forgetfulness and dementia, it is important to see whether it affects the activities of daily living and functioning of the patient. Now, we will move through the various etiologies of dementia that should be on your differential diagnosis when a patient presents with symptoms that could be consistent with dementia. Let's start with Alzheimer's disease. In Alzheimer's disease, patients typically experience a slow onset of dementia along with short-term memory loss. They also have language problems such as trouble finding words. In addition, patients have difficulties in performing activities of daily living such as cooking, tracking bills, and taking medications. Sometimes the elderly experiencing Alzheimer's disease can get lost in the familiar surroundings due to spatial disorientation. Later in the course of the disease, patients may also experience personality changes. Now let's move on to vascular dementia. In contrast to Alzheimer's disease, vascular dementia has a stepwise decline in executive functioning. This stepwise decline is related to gradual deficits associated with small vascular events in the brain. Usually, vascular dementia develops in people with risk factors for vascular disease, such as hypertension, hyperlipidemia, diabetes, and smoking. In question scenarios, the typical presentation is dementia in an elderly patient with the risk factors mentioned above, in addition to cerebral infarction and deep white matter changes on imaging. Now let's take a look at various findings in patients with Alzheimer's disease and vascular dementia that help make differentiation easier. This picture compares normal brain with the changes in the brain of a patient with Alzheimer's dementia. Typically, patients have diffuse cortical atrophy, as seen here on the right image. This next image shows senile plaques in a patient with Alzheimer's dementia. These plaques are made of beta amyloid protein, which represents the abnormally folded protein. Note that elderly usually have small amounts of these proteins, but in Alzheimer's dementia, there is an abundance of it. Here is the histopathology image depicting neurofibrillary tangles in a patient with Alzheimer's dementia. Neurofibrillary tangles are made of tau protein. Normally, tau protein stabilizes microtubules, but in Alzheimer's dementia, it sticks to another tau protein and creates accumulations, which interferes with the connections between neurons. As seen, this is a CT scan of a patient with vascular dementia, showing hypodense areas in the periventricular white matter, as well as basal ganglia. These findings result either from ischemic or hemorrhagic infarcts. A 78-year-old man is brought to the physician by his son due to worsening memory problems for 2 years. Initially, he used to misplace objects at home. Then he would get lost in his neighborhood, and now he has a hard time remembering who he is. Past medical history is significant for uncontrolled hypertension and hypercholesterolemia. The physical exam reveals right-sided hemiparesis. What is the most likely diagnosis? This patient presents with worsening memory problems for 2 years. Initially, he used to misplace objects at home when he used to get lost in his neighborhood, and now he has a hard time remembering who he is. These are the signs of stepwise decline in the patient's cognitive functioning. Considering his hypertension and hypercholesterolemia and the presence of the right-sided hemiparesis, this patient likely had at least one episode of stroke. Dementia, along with vasculopathy and the focal neurologic deficits, is consistent with the vascular dementia. Next, let's talk about frontotemporal dementia, which is also known as Pick's disease. In this case, patients have early onset of personality changes, disinhibition, apathy, and compulsive behavior. These changes may present as someone who is no longer able to behave appropriately in social situations, such as having hypersexual behaviors in public. Patients may also experience language difficulties, which can eventually lead to aphasia. On imaging, there may be frontotemporal atrophy that is apparent. Now let's move on to a discussion about dementia with Lewy bodies. The hallmarks of this type of dementia are visual hallucinations, fluctuating cognition, and Parkinsonism. Patients may also experience REM sleep behavior disorder, which is when patients do not experience atonia during REM sleep. Because of this, patients may act out their dreams during REM sleep, which may more frequently be noticed by family members who see them sleep than the patient themselves. In patients with dementia with Lewy bodies, symptoms typically start at an earlier age than other dementias. Now, let's again look at various findings in patients with Pick's disease and dementia with Lewy bodies. These MRI images depict atrophied frontal and temporal lobes, which is a finding typical in Pick's disease, which is also known as frontotemporal dementia. This next image illustrates the Pick bodies, which can be seen on pathologic exam postmortem. Notice these round cytoplasmic inclusions of hyperphosphorylated tau protein. Here is the gross image of Pick's dementia showing enlarged ventricles and atrophied temporal lobe. It is important to note that the ventricles can appear enlarged in most types of dementia. This is because as the brain tissue atrophies secondary to the dementia, the ventricles are able to fill with more fluid. This finding is also known as hydrocephalus ex vacuo. Here's an image showing Lewy bodies, which are made of alpha-synuclein. In Lewy body dementia, when under some sort of pathologic stress, alpha-synuclein undergoes a structural change and deposits as Lewy bodies, as seen here. An 81-year-old woman is brought to the physician by her daughter due to strange behavior for 6 months. On some days, the patient behaves as usual, but on other days, she is irritable and cannot recognize her daughter. She also claims that she sometimes sees 2 tigers at home. 3 months ago, she started expressing postural instability, shuffling gait, and a resting tremor. What sleep disturbance is expected in this patient? This patient presents to the physician due to strange behavior for 6 months. On some days, the patient behaves as usual, but on other days, she is irritable and cannot recognize her daughter. This pattern is consistent with fluctuating cognition. She also claims that she sometimes sees 2 tigers at home, which suggests she is experiencing visual hallucinations. 3 months ago, she started expressing postural instability, shuffling gait, and the resting tremor. These are signs of Parkinson's disease. Dementia with fluctuating cognition and visual hallucinations, along with Parkinsonian features, suggests the diagnosis of dementia with Lewy bodies. Dementia with Lewy bodies is commonly accompanied by REM sleep behavior disorder. REM sleep behavior disorder is when the patient gains motor control over their body during REM sleep and acts out dreams by moving, talking, or shouting. Let's take a look at another question. A 79-year-old man is brought to the physician by his son due to inappropriate behavior for the past 6 months. He makes sexually insulting comments to other family members. He has become irritable and rude. The patient also commonly forgets the names of his family members. His brain MRI shows bilateral atrophy of the temporal and frontal lobes. He dies 2 years after initial presentation. What is likely to be found on the autopsy of this patient? This patient presents with inappropriate behavior for the past 6 months. He makes sexually insulting comments to other family members. He's become irritable and rude. The patient also commonly forgets the names of his family members. These findings are consistent with the early onset personality changes along with dementia. His brain MRI shows bilateral atrophy of temporal and frontal lobes. All these clues support the diagnosis of frontotemporal dementia, previously known as Pick's disease. Autopsy of the patient with Pick's disease commonly shows round Pick bodies in the cerebral neurons. Pick bodies consist of either hyperphosphorylated tau proteins or ubiquitated TDP43. Let's take a look at some other etiologies of dementia. Let's discuss normal pressure hydrocephalus. Patients with normal pressure hydrocephalus present with typical triad of symptoms such as ataxia, urinary incontinence, and dementia. These patients have a magnetic gait, which is often described as a slow, broad-based gait with short steps, and their feet seemingly stuck to the floor. The dementia presentation associated with normal pressure hydrocephalus is similar to other conditions in that patients have trouble concentrating, planning, controlling finances, taking medications, etc. These symptoms result from an improper production and absorption of CSF, leading to increased size of the ventricles and distortion of the surrounding structures. On imaging, we usually can see the dilated ventricles. Next, let's talk about prion disease. Prion disease differs from other types of dementias in that it often has a characteristic rapid onset and rapid progression. Patients have a rapid acute onset of myoclonus, seizures, and behavioral changes. The myoclonus may also present as startle myoclonus, where the patient experiences episodes of myoclonus when they're startled or surprised. This condition results from abnormal protein accumulation and worsens over weeks to months. Finally, let's take a look at imaging and histopathology findings associated with these conditions. Here's an MRI depicting the enlarged ventricles in a patient with normal pressure hydrocephalus. It is important to note that in normal pressure hydrocephalus, the ventricles are enlarged without any evidence of an anatomic obstruction. Here's a biopsy image depicting spongiform changes in variant Creutzfeldt-Jakob disease, which is a form of prion disease that leads to dementia-like symptoms that rapidly progress. This change results from abnormal folding of proteins in the human body, which leads to neuronal damage and loss. On the following MRI images, hyperintense signals are detected in the cortex and basal ganglia, consistent with a diagnosis of Creutzfeldt-Jakob disease. Finally, let's talk about Korsakoff dementia. Korsakoff dementia results from thiamine deficiency, which lead to damage to mammillary bodies. This in turn results in antero-retrograde amnesia, lack of insight, personality changes such as apathy and impaired executive functioning. Korsakoff dementia diagnosis is made clinically, so the imaging and lab tests are not needed. Usually it develops in patients who drink a lot of alcohol, are on extreme diets, undergoing chemotherapy, or on dialysis. A 47-year-old man is brought to the physician by his wife due to unusual behavior for 2 months. He has become aggressive and rude, and he frequently forgets his children's names. He underwent corneal transplantation 4 months ago. The physical exam reveals ataxia and occasional myoclonus. EEG reveals periodic sharp waves. CSF analysis shows increased 14-3-3 protein. What is the most likely pathophysiology of this patient's condition? This young patient presents with unusual behavior and memory impairment for 2 months. He has become aggressive and rude and frequently forgets his children's names. The physical exam reveals ataxia and occasional myoclonus. EEG reveals periodic sharp waves. CSF analysis shows increased 14-3-3 protein. All these clues suggest a diagnosis of iatrogenic Creutzfeldt-Jakob disease, which is a prion disease. The patient likely got Creutzfeldt-Jakob disease from his corneal transplantation surgery. Prion diseases are caused by accumulation of abnormal prion proteins in beta-pleated sheet conformation. Abnormal prion proteins then convert the normal prions with alpha helix conformation into abnormal ones. Next, let's discuss clinical approach to dementia in detail. To diagnose a dementia correctly, thorough history taking and examination is necessary. Before making an assumption about irreversible causes of dementia, reversible causes should be considered. Therefore, a CBC, TSH, and B12 should be routinely checked to rule out anemia, hypothyroidism, and B12 deficiency as an underlying cause of cognitive changes. In select patients, folate and VDRL can be checked. For example, an alcoholic patient should get folate level measured, while a patient with multiple sexual partners and unprotected sexual activities should get a VDRL checked. Depression also needs to be ruled out by screening. Then a mini mental state exam should be performed. After this, if the mini mental state exam suggests cognitive dysfunction, then imaging such as CT or MRI could be done to see if there is ventricular enlargement, cortical infarction, or atrophy, suggesting an underlying cause of the patient's symptoms. Let's take a closer look now at the components of the mental state exam. Here's a table showing the components of mini mental state examination. As seen, orientation is checked by asking about patient's name, location, date, presenta fact. Registration is checked by asking a patient to repeat 3 object names proposed by the doctor. Attention and calculation is checked by asking a patient to subtract 7 from 100 at least 5 times. Recall is checked by asking the names of 3 objects the doctor told the patient earlier. The language component is checked by asking a patient to name 2 objects, repeat no ifs, ands, or buts, giving a 3-stage command, asking to read and obey a written command, and finally asking the patient to write a sentence. Copying skill is checked by asking a patient to copy a pair of intersecting pentagons. Overall, if patient scores from 24 to 30, she or he has no cognitive impairment. If a patient scores from 18 to 23, she or he has mild cognitive impairment. Finally, if a patient scores from 0 to 17, he or she has severe cognitive impairment. A 72-year-old man comes to the physician reporting severe forgetfulness for the past 3 months. Once he forgot to turn off the stove, which resulted in a house fire. Sometimes he has trouble remembering his son's name. The patient has been living alone after his wife passed away 6 months ago. He no longer enjoys playing cards with his friends and has trouble falling asleep. The patient feels sad and does not want to get out of the bed most days due to him feeling like he moves slower than he used to the point that his family has noticed. Which intervention is likely to improve this patient's current condition? This patient presents with severe forgetfulness for 3 months. He's been living alone after his wife passed away 6 months ago. He no longer enjoys playing cards with his friends. This behavior is consistent with anhedonia. He has trouble falling asleep. The patient also feels sad and does not want to get out of bed most days due to slowness of movement, which is consistent with psychomotor retardation. Therefore, this patient meets at least 5 criteria of major depressive disorder lasting for at least 2 weeks. Memory impairment in the elderly in the context of depression is called pseudodementia. Pseudodementia, along with other signs of depression, is likely to improve with psychotherapy and antidepressants. Let's now elaborate on treatment. Patients with Alzheimer's disease are given acetylcholinesterase inhibitors such as donezepil, rivastigmine, or galantamine. If these medications don't work or there is contraindication, an NMDA receptor inhibitor, memantine, can be used instead. In addition, behavioral therapies and psychosocial support is crucial. In terms of vascular dementia, patients typically are advised to modify their lifestyle, including weight loss, consuming a low-salt diet, and quitting smoking. Furthermore, they should treat the underlying risk factors such as diabetes mellitus, hypertension, and hyperlipidemia. Let's take a minute and discuss the mechanism of action of various medications used in neurodegenerative diseases using this illustration. As we have mentioned previously, patients with Alzheimer's dementia are managed with donepezil, rivastigmine, and galantamine, which, as seen here on the image, inhibit acetylcholinesterase, hence increasing the levels of acetylcholine. In case of contraindication or ineffectiveness of above-mentioned medications, memantine can be used. Memantine is an NMDA glutamate receptor inhibitor, which decreases the progression of the dementia. An 88-year-old woman is brought to the physician by her daughter due to gradually worsening memory impairment for 3 years. Initially, the daughter thought it was normal age-related decline, but the patient is severely deteriorated. She cannot recall the names of her family members, and she often gets lost in her neighborhood. Lately, she's become irritable and does not talk to anyone. Which class of medications is the best initial treatment option for this patient? This elderly patient has gradually worsening memory impairment for 3 years. She cannot recall names of family members, and she often gets lost in her neighborhood. Lately, she has become irritable, and she does not talk to anyone. Initial symptoms of dementia, followed by personality changes and mutism, are consistent with the diagnosis of Alzheimer's dementia. The best initial treatment options for Alzheimer's dementia are cholinesterase inhibitors such as donepezil, rivastigmine, or galantamine. Next, frontotemporal dementia is managed symptomatically by physical therapy, speech therapy, SSRI, and antipsychotics with caution. Antipsychotics can help with agitation but need to be used with caution in this patient population due to an increased risk of mortality and the adverse effects that can be seen with antipsychotics. Dementia with Lewy bodies is treated with donepezil, rivastigmine, galantamine, or memantine, similarly to Alzheimer's disease. In addition, levodopa and haloperidol are given for Parkinsonian symptoms and psychosis resulting from increased dopamine levels. Next, we continue with the management of normal pressure hydrocephalus. As we have mentioned earlier, these patients have ventriculomegaly secondary to decreased absorption or increased production of CSF. In these patients, a trial lumbar puncture can be completed to see if the patient has symptomatic improvement after removal of CSF. If so, then a lumbar drain trial can be performed where the catheter is left in the space to see if there is improvement to determine if the patient would be a suitable candidate for ventricular shunting. If a patient improves with multiple lumbar punctures or a lumbar drain trial, then a ventricular shunt should be placed. For Korsakoff dementia, which is irreversible, patients are first given thiamine, then glucose. It is important for these to be given in the correct order, since giving glucose before thiamine can further diminish thiamine stores and worsen encephalopathy. Overall, most of the patients need lifetime care because they are not fully responsive to this supplemental therapy. Lastly, in terms of management, there is no effective treatment for a prion disease, and unfortunately, the most likely outcome is death. A 67-year-old man is brought to the physician by his daughter due to gradually worsening memory impairment for 3 months. He often forgets names of his children and grandchildren. The patient suffers from urinary incontinence. The physical exam reveals an abnormal gait with alternating feet sliding on the floor. Brain MRI shows ventricular enlargement. What is the best initial management option for this patient? This patient has memory impairment evidenced by forgetting the names of his children and grandchildren. He also suffers from urinary incontinence. The physical exam reveals an abnormal gait with alternating feet sliding on the floor. This is consistent with magnetic gait. The triad of wet, wacky, and wobbly, along with ventricular enlargement on brain MRI, is consistent with the normal pressure hydrocephalus. The best initial management option for a patient with normal pressure hydrocephalus is a lumbar puncture to see if there is improvement in symptoms. If there is an improvement in symptoms, then placement of a ventricular shunt can be considered for long-term management. A 65-year-old man is brought to the emergency department by his friend due to severe agitation and aggressiveness. His past medical history is significant for chronic alcohol use for 45 years. The patient tells stories which are inconsistent with what the friend reported. He does not remember his family. The patient's friend says that he used to be a friendly person, but he changed over the course of 2 to 3 years. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 135/80, heart rate of 81, and respiratory rate of 13. Physical exam reveals disorientation, abducens nerve palsy, and truncal ataxia, supplementation of which nutrient could have prevented this patient's current condition: A. Cobalamin, B. Folate, C. Thiamine, or D. Niacin. This patient with a 45-year history of alcohol use disorder presents with severe agitation and aggressiveness. The patient tells the stories which are inconsistent with what the friend reported. This clue suggests the presence of confabulations. He does not remember his family, indicative of retrograde amnesia. The patient's friend says that he used to be a friendly person but changed over the course of 2 to 3 years. Confabulations, amnesia, and personality changes in the context of chronic alcohol use are consistent with the diagnosis of Korsakoff syndrome. The physical exam reveals disorientation, abducens nerve palsy, and truncal ataxia. These signs and symptoms suggest Wernicke's encephalopathy. Therefore, this patient has Wernicke-Korsakoff syndrome. Although Wernicke's encephalopathy alone is reversible, Korsakoff syndrome is irreversible. Wernicke-Korsakoff syndrome is caused by damage to the mammillary bodies and dorsomedial thalamic nucleus due to thiamine deficiency. Therefore, thiamine supplementation could have prevented Korsakoff syndrome in this patient. The correct answer is option C. Here's our slide reminding us of the clinical features of Korsakoff syndrome. Take a minute to pause the video here and review the slide if needed. Let's discuss why other options are incorrect. Option A, cobalamin, is vitamin B12 deficiency, which can result in subacute combined degeneration of the spinal cord and dementia-like symptoms. However, B12 supplementation cannot prevent Wernicke-Korsakoff syndrome. Option B, folate, is vitamin B9 deficiency, of which results in macrocytic megaloblastic anemia. However, B9 supplementation cannot prevent Wernicke-Korsakoff syndrome. Finally, option D, niacin, is vitamin B3 deficiency, of which results in pellagra, with diarrhea, dermatitis, and dementia. Again, niacin supplementation cannot prevent Wernicke-Korsakoff syndrome. And that concludes our lecture on dementia.